we'd like to talk about, obviously, everything to do with oxygen. The main thing is, obviously, all the different ways and things we can support our patients with oxygen and how to give it. Okay, so the aims of this presentation today, okay, so we're going to identify when oxygen is needed. We can discuss the different ways of oxygen monitoring, and also to explain the different techniques of how to give oxygen. Okay, so oxygen supplementation, when do we need it? So 4 main reasons we need it is obviously when a patient is in respiratory distress, we have a patient with airway obstruction, and we have a patient that has got, for whatever reason, altered gas exchange and altered oxygen delivery. Okay, so first of all, signs of respiratory distress. Now this is one of the things I'm sure you've all seen at one time in your veterinary career. We have basically the orthopnic posture. It's the one where you've got the animals, they're coming in like this. They're usually standing, they've got an extended head and neck, a very wide stance, extended elbows, and the breathing is vastly different from what it should be. Their demeanour, they're very restless, they refuse to lie down, they can be stressed, they're panicked, the flared nostrils, the panicked eyes, they're sort of asking you to help them. And then the breathing is open mouth, rapid, noisy, all sorts of things like that, and obviously quite often they have got cyanode mucous membranes as well. Okay, so airway obstruction. This is usually patients obviously who are having difficulty obtaining oxygen. The 2 main reasons we see this is upper airway obstruction, so you've got a trauma to the tracheal area. It could be, you know, they've got a crushed trachea, they've got a obstruction, a ball, something like that. The second one is one we probably see very, very often is with our BOAS patients. Okay, we've all seen these, the short-nosed patients who, for whatever reason, they've run around too much, they're stressed, that sort of thing. They become shocky, and they obviously have a BOAS crisis. Okay, so the 2 main ways that we can test our oxygen levels. So the first one, which is on your left, obviously is a pulse oximeter. I'm sure it might not look like this, but you do have some sort of thing in your practice. This basically measures the percent of available oxygen in carrying of the hemoglobin. As you can see, this was on me, and I wasn't that great that day, but you know, 100% is the ideal, but I was having a very stressful day. Okay, the next one is basically a radiometer, or as we call it, a NOVA. This measures the arterial partial pressure of oxygen, or in short, PaO2. So going back to the pulse oximetry, it's a very non-invasive method that measures the hemoglobin content of blood in the oxygen carrying cells. It gives us an idea of the efficiency of the gas exchange from the inspired air to the alveoli to the body tissues. Okay, best places to take this, obviously the most hairless place possible, so obviously the tongue if anaesthetised, the lip is one that's very common, obviously unpigmented is the best place, ears, the vulval prepuce, the toe beans, obviously in cats, the little toes, and the webbing between the toes on dogs. Okay, ideally, as I was saying before, it should be between 97 and 100%. Under 95%, they'll probably need to have some sort of oxygen supplementation. Between 90 and 93, we really start to worry about them, and we start to worry about hypoxemia. One thing to remember is obviously with when they have a probe on, is not to leave it in place too long. And we're talking like sort of hours and hours. You know, an anaesthetic, half an hour is absolutely fine. But also it can start to cause false readings, and also it can start to cause tissue damage as well. So, blood gas. Okay, this is an invasive way to test the partial pressure of the oxygen. We do this ideally from arterial sample. The arterial samples can be taken directly from an artery, although when taking that, always remember to apply a lot of pressure afterwards. Or for multiple samples, we'll put in an arterial catheter. When placing an arterial catheter, you just need to be very aware. It's very tricky to do because of the size of the artery and the friability of it. I've done a little drawing here of the 3. There's about 5 or 6 places you can use to put an arterial catheter in, but these are the 3 main ones we use. Okay, so you've got obviously the coxsacral artery, which is obviously here on the tail. You've got the dorsal metatarsal, or most of us just call it the pedal artery, and you've got the auricular artery. So obviously this one on here is very good for those, you know, basset hounds, that sort of thing, the really massive eared patients who've got short, stumpy legs. Okay, so we're only literally just going to pass over this, but basically blood gas results. The idea of looking at or taking a blood gas is ideally to have them off oxygen for about 5 minutes, if possible. A little bit longer if you can, but usually these patients are so dependent on oxygen you can't do it much longer. And when we're looking at the results, you're looking at if it's a PaO2 of less than 90, you're talking about mild hypoxemia. Less than 80 is moderate, and if it's less than 60, you're looking at very severe hypoxemia. If you're unable to take them off the oxygen, you just have to remember that when you are putting the blood into your machine, you have to remember to add the FiO2 to the machine at the time. Okay, and our machines will calculate the PF ratio. Now this one here, I've tried to do it simply what the PF ratio is, but basically a rule of thumb for a healthy patient, the PaO2 should be roughly 5 times the inspired oxygen. So if you put that in, like with this one here, I've done a little bit of an example. You've got a patient that's on 2 litres of oxygen and it's got nasal prongs in. So you're looking at, you've got 4% per litre. So if you look at the calculation a bit lower down, you've got the room air is 21% plus the 8% by the oxygen in the nasal prongs. You times that by 5 and you're looking at, it should be around 145 millimetres of mercury should be the optimal result. We'll then get our reading back from our machine, and from those results, if it's above the, or 145 or above, we're looking at it's good oxygenation. If it's anything less than 145, we're looking at some sort of mild, hypoxemia. Okay, so one thing before we go into obviously how the different ways we can deliver oxygen, is one thing to mention is humidifying oxygen. Now, oxygen is a very dry gas and can be very, very irritant to the mucous membranes, especially when it's used long term. If it's less than an hour in a really, quick, emergency, then it's fine. But anything longer than an hour, it needs to be humidified. We use things, basically bubble humidifiers. I don't know if you can see it here, but there's a line across here. This has basically got water in. Ionised water, sterile water, anything like that is absolutely fine. What happens is, we turn this oxygen on here, it comes through here, it bubbles through here, and then comes out through this green tubing to the patient. So basically, the oxygen is now moistened, and so they get humidified air. One thing as well, again with this, you need to try and use the lowest amount of oxygen that is needed for the patient. Okay, so ways to supplement oxygen. So I've split it into 3 groups. General one is one that you'll use most of the time in general practice. It's basically a buster collar with clean film on. This is something that, when I first started nursing was something that we did all the time. I think it has gone a little bit out of favour at the moment, but it's very Heath Robin, but it's still a very good way to be able to do it. Flow by with a mask or a circuit, nasal prongs, nasal catheter, and basically an oxygen cage or an incubator. The middle category is advanced. You've got the basic transtracheal catheter, tracheostomy tube, intubation, and then a specialised one, which some of you might be lucky enough to have, is high flow or mechanical ventilation. So we're going to the first one. There's just a few, obviously, pictures here. We've obviously got the buster collar with a clean film. We've got the mask, nasal prongs, nasal catheters, and then the oxygen machine. So just quickly, I have put techniques of this, but I won't bore you with the techniques, but it just tells you a bit about how to do each thing. This is, a very, it's a very Heath Robinson way to do it, but it can be a very, very easy, cheap way to give oxygen to a patient if you haven't got any other methods. The one thing you do have to remember with this is to make sure when you put the clean film over the buster collar that you leave a gap at the top of the clean film to prevent hypothermia. This actually doesn't affect the oxygen delivery at all, because oxygen is heavier than air, so the actual oxygen will drop down to the bottom. So I don't know if you can see here, although the oxygen tube is actually at the bottom here, I think that's for the cat's sake. There's a hole just up here, and say the oxygen is all down here. Okay, second one is flow by mask. Now I'm sure you can either do it from green tubing, which you saw earlier on with a humidifier, or you can do it from a circuit. One thing with this is, ideally, you need to place the mask over the entire muzzle if possible. Most animals actually don't like that much, especially if you've got like, the black diaphragm on as well. They really don't like it, so we tend to put it as close as possible. Again, because oxygen drops, the idea is to place it just a little bit above the nares, and then the oxygen will drop and hopefully get into the nares that way. Okay, next one is nasal prongs. Now, with nasal prongs, I have my lovely assistant here. This again is something that can be very easily done in practice. You don't need too many accessories. You basically just need some nasal prongs here, which you can get from most places, and just basically some proximeticam, and that is all. So what we do is we tend to put the proximeticam into the nostrils. I know, it's fine. Usually wait for about 5 to 10 minutes. Obviously keep them calm. If they do need oxygen while you're doing that, so you just have flow vibe near them. You then basically, give them a nice calm cuddle. You get the nasal prongs. You put them over the head, into the nostrils, under the ears, and then you tighten it at the back. Okay, and it is as simple as that. Obviously, the end bit then we attach to humidified oxygen. Okay, this actually, can be very well tolerated. You have to make sure that you do keep replacing the proximeticane. After a few hours, that will wear off, and obviously when they start to, pour at it, get it out, that sort of thing, it is an idea just to replace the proximeticane. One other thing to think about is, obviously, with most of these patients, we do have to put a buster collar on as well to stop the patient interference. Okay. Again, oxygen must definitely be humidified because it's going straight into the nostrils. And again, if the patient is panting, this is not the ideal method. Okay, so nasal cannulas. This again can be done in general practice. I've just got a list of the equipments here. But again, it's a bit like, as Laura was explaining earlier on, how you place the feeding tube. It's just obviously a slightly different position that you put it into. Okay, so you've got a list of all the equipment here and everything you need. And ideally for this, a feline, you're looking at about 5 to 6 French, and canine, 6 French to 12 French. It doesn't need to be humongous, it just needs to fit into that nostril. Okay, so with this, there's just a big thing about all the technique. Again, probably exactly the same as Laura explained earlier on. The only thing you need to do is to make sure you pre-measure this catheter. So obviously with this, we pre-measure from the nostril to the medial canthus of the eye. We then would mark on a line where it goes to, and then pre-lubricate, and then you'll just make sure that you'll obviously aim ventrally into the ventral meatus until you get to the pre-marked line, and then you would just put it around the side of the head. Now again, people have 2 different ways of doing it. Some people like to do it up through the middle between the eyes, or others like to do it around the side of the face. Either way doesn't matter. You can also do, like with the feeding tubes, you can do the finger, thank you very much, the finger trap method to secure it, or you can do the tapes and suture it in, or you can do the gluing, or again, the staples. Again, it is a complete preference. Again, with this, it needs to be humidified, and you need to think about using the lowest flow rate possible to avoid, to avoid tissue damage. With this, there is a couple of contraindications. Things like if there's a big, massive nasal trauma, obviously it's not the ideal. Tumours, any sorts of coagulopathies, so blood clotting disorders, especially things like thrombocytopenia, it's a no-no. And also, if we're talking about head trauma cases, although it seems like it should be the ideal thing, we have to obviously think about all the, fiddling and that around may increase the intracranial pressure. That's something we need to think about as well. Okay, so going on to the oxygen cages. Now this is one that I think a lot of people might have something looking like this in your practice. Okay, it's an incubator here, and then we've got our 2 lovely oxygen cages here. Okay, so going on to these two first, these are both things that you may have in practice. So you've got the collapsible oxygen cage. It's basically a convenient, very cheap way of giving short-term oxygen to smaller patients, especially if you need to travel anywhere. You can have portable oxygen and travel with them in this cage. One thing you must be very aware of is that they can overheat very quickly. So again, what you can do is you can make a little hole in it or open it up a little bit, and the oxygen should still obviously still work as it drops to the bottom. One good thing about it, it can be folded away and stored very easily. Okay, next thing we come on to is the incubator. As you can see here, if it's one of the newer incubators, you can actually attach the green tubing here. There's a little thing here, you can actually attach the oxygen straight to it. Ours, unfortunately, cannot, so what we do is we have the green tubing, it just goes through one of the holes here and goes to the patient there. But very, very useful, especially if these patients need warming up at the same time. So going on to the big oxygen cages. Now, obviously it's specialised equipment. Outlay can be expensive and needs to be constantly well maintained, but these are a godsend. It's non-invasive, it's very patient friendly, and it provides a lovely oxygen-rich environment. And we are very lucky because we've got a little box here, and that will basically lets us tweak the oxygen concentration, the humidity and the temperature as and when we need it. The only thing you have to do, make sure is in this little bit here that make sure we change the water and the soda lime. We check it every 4 hours, but that's something you need to be aware of. Another good thing to think about is obviously we are not to place any electrical items in this closed box here. That has been, don't know myself, but there is a chance that they could blow up. So you can have an ECG, like a mind rate monitor outside and have the wires going through, but you can't have things like pulse oxes and stuff, actually the actual box in there, because that would not be good if they blew up. Okay, so going on to the advanced ones, you have transtracheal catheter, tracheostomy tube, and basically intubation. So the transtracheal catheter, now this is not so common nowadays as it used to be, but it's a very handy thing to actually have at the back of your mind or even be aware how to do, just in case you have those instances when you've got a patient that's rushed in, who's choking on a ball, it's gone blue, you can't do anything else, you can't tube it or anything like that. This is, you haven't got a tracheostomy tube, this is a good thing to be able to do to get some oxygen getting into that patient. Okay, again, you don't need that much equipment for it. And it's actually a very, very simple way to place it. So going on to tracheostomy, again, this is something that ideally the patient is usually either heavily sedated or anaesthetised. But again, this is something that with our little BOAS patients that they sometimes might need. Things to think about are the sizing of your tracheostomy tube. Usually it's 60-70% of the diameter of the trachea, or in a rush, we basically go for a size or a size and a half smaller than the ET tube that you think they would need. It must be paced by a vet, and as I put here, must be anaesthetised. Patient must be kept very, very quiet and calm and always under 24-hour supervision. So this is not the sort of thing that can be moved around from like a day vet to a night vet, that sort of thing. They need to be kept calm, quiet, and ideally at the same place. Things you need to have always around is a suction machine, an emergency intubation tray, and they must always be kept close by, and we tend to, if we can, have one nurse to this patient. Okay, a tube. So obviously once intubated, a patient could be attached to either an ambu bag or a circuit, an IPPV started. The patient will obviously receive 100% of his oxygen that's being delivered to them. This is very time and labour intensive, so you need to make sure there's lots of people around to help. One thing we do is we tend to use an ambu bag here rather than a circuit, and we have to make sure that we always have a PEEP valve, which is this one here, and an in-circuit pressure manometer on at all times. Okay, so with the PEEP valve, it basically is used to provide a positive pressure to the lungs at the end of the exhalation. It just basically prevents the lungs from collapsing, to make sure there's always some air left in there. And with the in-circuit manometer, it measures the amount of pressure being entered into the lungs. I don't know if you can see it, but on here there's obviously green, yellow, red. green is the ideal, yellow is it's just about right, and red is a no-no. You can't see the numbers on here, but ideally we need it to be between 13 and 15 centimetres of water. Okay, so going on to specialised equipment. Here on the left we have our high flow machine, and here on the right we have a ventilator. I'm not sure if any of you have got these sort of things, but it's the sort of thing that you'll see in most referral centres. So first off, talking about the high flow oxygen therapy, just in these pictures you've got, that's the actual, what the machine looks like, a close-up of it, and this is the prongs that go into the patient's nose. There are actually human ones, but they have adapted very well to the animal world. I mean, sometimes we have to ad-lib a bit by adding a bit of tape here and there, but they do tend to tolerate it very well. Okay, so with the high flow oxygen therapy, or HFO2 as we call it, it's a non-invasive technique which we used, say using machine and equipment like I suppose. It delivers warmed, humidified oxygen at a higher flow rate than the traditional methods we've spoken about. And it's a very good bridging method between traditional methods and going on to that mechanical ventilation. It's often used to improve the respiratory effort and to make the patient more comfortable. And it's very, very useful on patients that are far too big to go into our oxygen cage. Okay, so mechanical ventilator. This is the one we have here. As you can see earlier on from that video as well, this is our lovely cot. This is where we tend to use it most is with our ventilator patients. Unfortunately, some days we have 2, maybe 3 on a really bad day, ventilators going. So what we tend to do is we tend to borrow this one here from anaesthesia as well. And unfortunately on this day here, it was a very bad day, and we have both these patients on tables because both our cots were in use as well. So you can imagine that was a very bad day that day. So, mechanical ventilation. This isn't a very invasive technique, again using the equipment we've talked about. The patients must be anaesthetised and intubated or heavily sedated, if a tracheostomy tube is being used instead of the AT tube. Usually it's used for patients that cannot effectively breathe on their own. So they've got a really bad case of hypoxemia, they may be respiratory fatigued or in respiratory distress. We think it will help their care if we take over for them. So what we do is we heavily sedate them, anaesthetise them, and we take over their breathing for them. This is the one bad thing about this is obviously it leaves a lot of monitoring and one-to-one care, but again these patients are very, very satisfying to nurse. So this is just basically a quick list of explains that basically no matter what literage, so how much litres you give these patients of oxygen, this tells you the percentage of that each of the ways to give oxygen will give them. I've got a couple of last slides. One thing to always think about is oxygen toxicity. Now this is very, very rare in animals, but it's something that everyone needs to be aware of that it may happen. It can occur anything from 3 to 72 hours post starting oxygen, but it only really occurs in rates of very, very high oxygen supplementation. So if you're looking at from about 5 sort of litres upwards, but again, it can happen at any time. This unfortunately will cause damage to the tissues in the lungs and the alveoli and could cause worsening lung disease. This is why we regularly we check our SpO2, so just so we can keep an eye on it and we can downgrade the oxygen levels that we are supplying as soon as possible. One last thing to think about is obviously eye lubrication. Now you need to always remember to lubricate the patient that is on oxygen. You can never have too much lube. So basically, the one I wasn't going to say that, and you're thinking about those who have a reduced or no blink, animals that are anaesthetised or heavily sedated, or animals that are basically in that sealed oxygen cage. You think about it, they can't get away from that oxygen, it's there all the time. Ideally, you need to apply every 2 to 4 hours. If you are thinking of someone in an oxygen cage, we're more likely to use sort of a gel as opposed to a drop because it will last a bit longer. We might be able to eke that out to the 4 to 6 hours. Ideal is to use preservative-free drops and the gel to protect the surface of the eye and to reduce the occurrence of dry eye and corneal ulcers. So, just as a last thing to say, even though animals are on oxygen, it doesn't mean they can't go out for a walk. It means they can go and have a walk in the garden, they can go and sunbathe in the garden. We've got a lovely little portable thing here that we can attach the oxygen to, and it goes to, and we can walk them out and they can be as normal as possible. Some animals unfortunately are on oxygen for quite a long time and they get very depressed, very sad being in the kennels, so this means they can go out literally into the garden. In the summer they can have a sunbathe, they can have their dinner out there, that sort of thing, and they can still receive the oxygen at the same time.